So welcome everybody to our first JBI Live Webinar. It's an absolute pleasure to have you all joining us today virtually. My name is Zach Munn. I'm an Associate Professor at the University of Adelaide and the Director of Transfer Science at JBI. And it's my absolute pleasure to be hosting this webinar for you all today. We have an excellent speaker lined up, Professor Zoe Jordan, who will be talking us through evidence-based healthcare during the pandemic. Which we are all looking very much forward to. So just quickly, we'll run through some logistics for the webinar. So as I said, a huge thank you to you all for joining our first webinar. This is the first in a series of webinars. We'll be doing these monthly, and we hope you get a lot of enjoyment from them. Now, we do want to interact and engage with you all during this webinar as much as possible. So you will have noticed that you've joined this webinar in listen-only mode. But that doesn't mean that we won't be able to hear from you. You can interact via the chat, and I'd encourage you all to use the chat to interact and make comments on the presentation. You're also able to ask questions using the Q&A functionality, which you'll be able to see in your little Zoom bar as well. So if you have any formal questions for Zoe, please do enter them via the Q&A. So you will be able to ask questions, and we will have a recording available after this webinar, which will be available via the JBI YouTube channel. And I encourage you all to subscribe to that channel. Just as we're getting started today, I would encourage you also to just use the chat to say hello, to introduce yourself, and let us know where you're from as well. That would be fantastic to see who's joining us and from where today. We did have close to 200 people register for this webinar, which is a great result. So it's fantastic that you could all join us this morning or evening or afternoon, whatever it may be in your time zone. So our speaker today, and I'm very pleased to introduce her, is Professor Zoe Jordan. Now, Zoe has been working in the field of evidence-based healthcare for over 20 years. She is the Executive Director of JBI, leading the organisation and our 70 collaborating entities across the globe. She has particular scholarship inquiry interests in communication, collaboration, and the role of empathy in knowledge translation. She has held many grants, published many papers, and won many awards, probably too many to run through today in this short time frame. She is also an excellent mentor, friend, and boss. And I'm very, very pleased to hand over to Zoe to start the presentation today. Thank you, Zoe.
Thank you. That was a very kind and generous introduction. I'm just going to share my screen. Okay. It's very exciting inaugural webinar, so thank you for inviting me to give this presentation. I always find those introductions really funny things. A canvas, after all, can be painted to depict whatever you choose. But just to add a little bit of real-life colour, perhaps, to that lovely portrait, thank you, Zach, that you've painted. I wanted to share with you my memory of starting work at JBI, because this year I celebrate 20 years of working in JBI. I can't believe it. Luckily for me, when I started, I had a wealth of healthcare knowledge. I had, after all, watched every episode of ER on television, been to the GP on several occasions, even had a short overnight stay in hospital, I think, as a child. This is where I would ordinarily pause to make sure people were laughing, because clearly I am joking. I had no clue whatsoever of the complexity of healthcare. I'd never heard of a systematic review. I'd certainly never heard of a clinical audit. But I learned very quickly and with significant admiration about what it all meant and how extraordinary the people responsible for all of this work were and are. And I've never looked back, only forward. We never had a chance with my predecessor to look back with the very clever and innovative Professor Alan Pearson. And every day I attempt to follow that lead, but sometimes I think it's important to look up before we can move forward. And so that's something that I'm hoping to deliver in this presentation. So welcome to everybody participating, and thank you for your attendance. As Zach said, I think there are people who are attending from all over the world, so I hope that the timing is not too inhospitable for you. Oops. Now my slides are not, there we go. So before I start, I just want to give an acknowledgement of country. I actually had to look up how to do this online for a webinar because I'd never done it before. But I'd like to acknowledge that I'm delivering this webinar from the lands of the Kaurna people here in South Australia. I also acknowledge the traditional custodians of the various lands on which all of you work today, and the Aboriginal and Torres Strait Islander people who may be participating in this webinar. I'd like to pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connection to the lands and waters of Australia. Just a couple of disclosures, nothing very surprising there, and I don't think anything that presents a huge conflict, but I am obviously the Executive Director of JBI, as Zach said. We have a commercial partnership with publishing house Walters Kluwer Health, and I am a member of the JBI Grade Centre. So this presentation is going to be divided into 3 parts. When I was first asked to talk, the topic was quite generic, and I have to admit I was a little bit hesitant to talk about COVID. Unfortunately, I think it's kind of inescapable, and I do think it has afforded us an opportunity to think about what we can do differently. So that's the approach that I'm going to take today. So part 1, is it the pandemic we had to have? Over the last, I'd say almost 20 years, we've had warnings about some pretty serious bugs that have had the potential to have widespread global impact, such as some of those listed on the slide there. Thankfully, here in Australia, we were largely unaffected by these, although much was made of their potential threat in the media. Unfortunately, I think this meant that when COVID first emerged, there were many, myself included, who perhaps didn't think it would reach our shores, or certainly not in a significant way. Perhaps a bit of the boy who cried wolf syndrome. Despite that, and lucky for us, much of what was in place in Australia proved to be robust and fit for purpose, although there really is no way that any health system in any country really could have built capacity to deal with something like COVID. So why perhaps is it the pandemic that we had to have? Well, it's forced us, as I said, to look at the world differently. We are implementing much more robust hand hygiene, social distancing, we're wearing masks, we're staying at home, we're working differently, we're Zooming. I don't know about all of you, but I've certainly had a bit of Zoom fatigue over the last few months, and it's quite a different way to interact with each other. We've been living differently, no restaurants, no cafes, no bars or pubs, which has been terrible for Australians. Only takeaway, limited numbers of people in a room, no playgrounds, which for parents has also been a real struggle, no shopping or online shopping. Stockpiling of toilet paper I never really did get my head around, but apparently that was a thing as well. So it's looked quite different, our day-to-day lives. But also the impact has been global, the economy and economic policy, unemployment, poverty, travel and tourism, obviously, health systems, food security, education, the way that we're delivering education, the way that we live, work, do business, and interact. There are a few parts of our lives really that will be untouched by the time this pandemic passes. So we know that you've had to change the way that you do things, both personally and professionally. I was relieved that at least Zach knew the reference of this picture to an episode of Friends where they were trying to pivot a sofa up a stairwell. But we're interested to know, or I'm interested to know, what are the things that you've had to change that you perhaps hope will remain after COVID? So we've got a few options for you there. As I said, a lot of us have been working remotely, learning remotely. We've had a bit more family time, which I've really enjoyed, but I know perhaps others haven't. We've had a lot more flexibility in our time, and perhaps the increased opportunity to do things that are good for our own health and well-being, like exercise. So I'm just going to give you a few moments to put in your options there.
So we're seeing everyone put their votes in, which is fantastic. Everyone's very actively filling out the poll, Zoe, and I'll share the results in just a second. About 50% of people have provided a response so far, and I'll just give it a few more seconds before finishing it off, because a few people are still providing some votes. Okay, all right, so I'll close that off now. And everyone should be able to see the results of that poll.
Great. So yeah, I mean, I suppose it's not really surprising. Working remotely and having a bit more flexibility seemed to be fairly high on people's lists. Learning remotely, that's interesting that that's a bit lower. And having, you know, more family time. So, so interesting results there. So pivot is a word that we've heard used quite a lot, certainly in the business world over the last few months. And a pivot, like what we've seen occur so extensively across all sorts of business cases with the advent of COVID, usually comes from a heightened awareness or a change in perspective. It occurs when you realise that there are other alternatives or possibilities available to you. But for most of us, this doesn't happen easily. Humans are creatures of habit, after all, and we don't always take kindly to the idea that we need to change. So I would encourage you to look up the Look Up project, or Google the Look Up project, which was launched in January of last year, 2019. Look Up is described as an invitation to live life with deeper connection to your surroundings and to each other. It's perhaps a gentle nudge or a reminder for us all to engage more fully in the world around us, and to the people that we share it with. Perhaps turning left instead of right, walking more slowly, noticing the details, sitting still, giving time, creating space, breathing out, daydreaming, looking up, looking at each other, which is extraordinarily difficult to do on a webinar, but being here and being together. And I'm a little ashamed to say that although the statistics on this campaign were quite impressive, I actually didn't notice anything about it until I started to prepare for this webinar, which perhaps shows you how much I was looking up. In fact, I think I noticed a sign on a bus about 2 weeks ago, and I suspect I'm probably not alone in that. So for many years, reflection, which is ultimately what we're talking about here, has been considered good practice in health and medical education. So many of you will be familiar with that. Mindfulness is another related concept that's strongly advocated for by psychologists. And they help to strengthen resilience, confidence, and creativity, among a whole host of other benefits. The reality is that distraction kills abstraction, our ability to think differently. Our attention span, I read recently, has shortened by about a third over the last 15 years. And this cognitive load has inhibited our ability to think about things differently. I thought this was an interesting question. The last time you stood waiting for coffee, what did you do? Did you stare off into the distance, lost in thought? Did you chat to someone else, or did you look down at your phone? Now, I am absolutely guilty, particularly when I'm by myself, obviously, of looking down at my phone, scrolling, emails. Not surprisingly, two of those things are actually really fantastic for your brain and body, and can have a fairly significant impact on your day and your life, and the other one, not so much. So for me, part of this experience of COVID has highlighted the importance of human connection with colleagues in the office, which is so different to how we connect remotely using technology like this. The differences are both physiological and psychological, and so having flexibility to work both remotely and in a physical environment can, to my mind at least, only be of great benefit to us all moving forward. Some of the benefits that are listed in the Look Up report are highlighted here on the screen on this slide for you. I'm not going to go into a great deal of detail about this today because it's not really the focus of this presentation, but I certainly encourage you to, as I said, locate the report and have a bit of a read. Okay, so I might pause there, Zach, just to see if there are any comments or questions before I get into part 3.
So far, we're all good, Zoe, so feel free to get into part 3. And just a reminder, and I would encourage you all to submit some questions via the Q&A functionality as well. Thanks, Zoe.
All right. So just in case there are people on the line who are unfamiliar with JBI, I thought I would give a quick overview. Now, we did a little bit of work earlier this year, actually, on telling our story. It was actually in preparation for a global sales meeting with our commercial partners, Walters Clover Health, and it was a really interesting exercise for us, particularly for those of us who have been working in JBI for a really long time. Because JBI is a bit of a complex organisation, and so trying to distill what we do can sometimes prove a bit challenging. So we went for a very traditional who, what, where, how, why approach. So we are now, I'm very proud to say, a leading global evidence-based healthcare organisation. We really hold our own with organisations like Cochrane and Campbell and GIN, to name a few. We do seek to provide the best available evidence, but we also want to provide education and software to support the use of that evidence. We work across more than 40 countries all over the world in partnership with really high-end experts. We're very proud of that. And ultimately, our goal, our vision and mission is around improving health outcomes. I just put this slide in this morning because I just came across it in my morning news feed, and I thought it was really interesting to see the total cases, which is only from a couple of days ago. Obviously, the US there still has the highest number of cases, not far behind Brazil, Russia, India. I'm sure this picture will change a bit over the coming weeks and months. But in thinking about my next slide, which is about the JBI collaboration. As I said, we work across 40 countries with more than 70 collaborating entities now, and you can see that there are some clusters of entities in some of the most affected areas by COVID. Each of these entities work in obviously a diverse range of contexts and settings and have experienced COVID very differently. For those of us here in Australia, that impact has been really comparatively minimal. But for those in the US, as we just saw, the UK, it's been quite different. I know of some colleagues in entities who have gone back to clinical practice, for example, in the UK. And of course, those in places like Africa, where the pandemic is really only just starting to take off, it's going to be very different again. They have poorer surveillance systems, abilities to conduct contact tracing, lack of access to resources like personal protective equipment and other infection control mechanisms. So COVID-19 has really been a powerful reminder to those of us in JBI of the inequities in healthcare across the globe, which makes these partnerships and the work that we do with all of you across the world, and I know that there are a number of you from the JBIC participating today, all the more important to us. Okay, so I think it's probably fairly safe to say that most health professionals now embrace the concept of evidence-based healthcare, and use evidence-based guidelines to inform, perhaps rather than direct, their practice. But simply defined, JBI would say that evidence-based healthcare can be conceptualised as decision-making that considers the feasibility, appropriateness, meaningfulness and effectiveness of healthcare practices. But we also have to take into consideration the context in which healthcare is delivered, individual patient preferences and the professional judgment and expertise of health professionals. EBHC doesn't eliminate the need for clinical reasoning and reflection by health professionals. On the contrary, the clinician requires enhanced clinical reasoning skills when deciding which evidence or recommendations to follow. And it's not so simple when a patient refuses or cannot be treated with an intervention supported by evidence, despite the fact that it might have been identified as the best course of treatment. So what is it that perhaps historically, I think it's changing now, but historically what has made JBI a little bit different to other groups internationally? And I'd argue that it's two things. I think the first really relates to our conceptualisation of what counts as evidence, in that it is more than just effectiveness. Of course, we need to know what works, but equally, and we're certainly seeing this at the moment, how much do these interventions cost? What interventions are actually available to us in different contexts, and what is the impact of those in different contexts? And how does a particular intervention impact on how a patient might feel or what they prefer? And in addition to that, we believe that it really is more than just information provision. We promote, but we also support evidence-based decision-making at the point of care. Our mission, as I said, is to create impact across health systems globally, but we can't achieve that if our information simply resides in a journal or database. It needs to be utilised in policy and practice. So I quite like the two quotes that I've got on the slide there, as I think they really reflect what it is we're trying to achieve. Research seeks to prove, but evaluation or implementation in our case seeks to improve. And knowing is not enough, we must apply. Willing is not enough, we must do. So as I was preparing for this presentation, I think it might have actually been Zach that flicked me this article by well-known academic Professor Trish Greenhalgh, who published in the Boston Review, and she highlighted the need to embrace multiple epistemic frameworks and methods to cope with the uncertainty and unpredictability of situations like this global pandemic that we're all living through. And I think this dual lens approach is certainly one that I can relate to, and I'm sure that many others who are listening can as well, as we collectively appreciate perhaps the limits of evidence-based healthcare in situations where the evidence simply doesn't exist. And it's a strong underlying premise of our very own model, which I'm going to talk about shortly. However, there's also been, I think, interesting examples of where evidence does exist, where it has done for hundreds of years, which is now only really being implemented in a robust way. So that brings us to our second poll. Before I start talking about the JBI model, I just want to gauge your familiarity with it. So we've got a few options there. I have an in-depth knowledge, I have some knowledge, I've seen it, but I don't really know much about it, and I've never seen it. So I'll pause for a few minutes to let people fill that out and hand over to Zach.
Looks like everyone's got the hang of polling this time around. We're getting everyone's votes in very quickly. All right, so we are above 80% of people have voted now.
Oh, that was quick.
It's looking like the responses are across the options. Okay, all right, I'll end that polling now and share the results.
Okay, so quite a few people with an in-depth knowledge, or at least some knowledge about it. Some of you have never seen it, so hopefully this helps you get a bit of an idea of what we in JBI consider to be the process of evidence-based healthcare. Okay. So the JBI model has been around for a while. It was initially developed in 2005, but we updated it in 2016. The inner circle represents the pebble of knowledge, which also, for those of you who don't know, appears in our logo. While the inner wedges provide JBI's conceptualisation of the steps involved in the process of achieving evidence-based healthcare, the outer wedges operationalise those component parts, and I think that was probably one of the biggest changes. We really wanted to reflect the pragmatism of the model as well, to articulate it in a pragmatic way. You might notice that there are some arrows which were also added in this revised version, which are intended to indicate that EBHC is not a linear process. Now, of course, those arrows could go all over the place because evidence-based healthcare can be bidirectional, but it can also, in reality, be very messy and go across all of those. But we do like our pretty neat model. So I'm just going to take you through the model piece by piece, or wedge by wedge as we refer to it. But I also want to offer some personal reflections across along the way. I have referred to it as post-COVID, which, as I was looking at my presentation this morning, I became increasingly uncomfortable with, because I don't think we're anywhere near being post-COVID, but for the purpose of today, that's what we're going to call it. So the first piece is the inner circle, which represents evidence-based healthcare. And as I've said already, JBI conceptualises evidence-based healthcare as decision-making that considers all of those things: feasibility, appropriateness, meaningfulness, and effectiveness. But also that it needs to be taken in conjunction with the context in which care is delivered, the individual patient and professional judgment. And I don't really think that that has changed as we've experienced COVID. As Trish Greenhill highlighted, you can't always afford to wait for gold standard evidence, but equally, evidence-based healthcare isn't only about effectiveness. It's not only about what works. So looking up during the pandemic has really reaffirmed that for me, I think. The importance of having that dual lens approach and being able to be pragmatic about our decision making, crisis or no crisis. The yellow wedge piece of the JBI model relates to global health and collaboration. And JBI believes that evidence-based healthcare really needs to be driven by the needs of our stakeholders. The achievement of improved health outcomes is seen as both the goal or endpoint, as well as the driving force of evidence-based healthcare. So to achieve that, we need to be able to identify knowledge needs through meaningful engagement with key stakeholders, which is on the right there, and in the middle. And if we do that, we really think that we're more likely to create sustainable change. So often changes occur, but don't necessarily last. Applying a mid-pandemic lens, perhaps, this idea of addressing global challenges in vastly different local contexts really requires a combination of both cutting-edge scientific capabilities married with detailed local knowledge. It is both an art and a science. And I know Professor Pearson used to talk about the art and science of nursing, and I think it's equally true of evidence-based healthcare. The coronavirus outbreak demonstrates that when problems emerge in distant places, they can quickly become a local catastrophe. So it's really critical that scientific responses are based on international collaboration that brings together the best minds, and data available from different countries for the benefit of everyone. Equally, though, it's important that the work we're doing is relevant to the community that we serve. So in pulling together collections of relevant work across our publications, it's been interesting for us in JBI to note the number of reviews being conducted that really truly have clinical relevance. And I was talking to the editor-in-chief of one of our journals about this just the other day, and to see those that don't. And as I said, it's really highlighted the need for really effective stakeholder engagement for us, I think. One concern post-COVID that I heard about on a local news program was the potential for something called vaccine nationalism. And that's the idea that countries who produce a vaccine might keep it to themselves instead of sharing it with the most vulnerable globally. And we've already heard accounts of some nations preventing the export of PPE, personal protective equipment like face masks. And so that was a major concern for me. For the synthesis community, however, it seems to have been a completely different story, which is a real relief. And groups have been pulling together to develop strategies to improve access to information, to avoid duplication, and to work more seamlessly and in a united way, in sheer contrast to that vaccine example. So I think that's really promising, and JBI is absolutely on board with that kind of approach. So I'd like to draw your attention to the third dot point, which is an international effort, COVID-19 or COVID-END, which stands for COVID-19 Evidence Network to Support Decision Making. And it's a really diverse group of people from across the world that have come together to help those already seeking to support decision making and find and use the best available evidence that's already out there. So supporting the evidence demand side, and also to help reduce, as I said, duplication, to better coordinate evidence synthesis, health technology assessment and guideline development. So on the flip side, to support those on the evidence supply side. And I've included the URL there. It is being run from McMaster, who many of you will be familiar with. And as I understand it, anybody can join up. So if you're interested, the link is there for you. So I'm going to move to the evidence generation wedge, the green piece of our model, which identifies discourse or narrative, experience and research as legitimate means of knowledge generation. And this has really been with us since our inception. It recognises that the results of well-designed research studies grounded in any methodological position, as well as anecdotes or personal opinion and expertise, are all deemed valid methods of generating evidence to inform policy and practice. And I think that's really true of the experience that we've had in the last few months. One of Trish Greenhouse's biggest criticisms of the UK government was their relentless and rigid application of principles of evidence-based healthcare, in that they wanted to wait for gold standard evidence to inform policy and practice decisions rather than using the best available evidence. So what counts as evidence in a post-pandemic world? Well, I think this experience, as I said, has simply confirmed to us in JBI our strongly held stance that, as Trish argued, a more nuanced approach to appraising the utility of diverse types of evidence is required. Not all types of evidence can answer the same questions. As I said at the start, we want to respond to questions that matter to those working at the coalface. And in the absence of what is typically deemed as high quality evidence, other sources simply must be consulted. So the evidence synthesis, or blue wedge, of the JBI model relates to the evaluation or analysis and collation of research evidence and opinion on specific topics to aid decision making in healthcare. Probably the piece that most of you are the most familiar with. The three main components of this wedge, to our minds, are systematic reviews, evidence summaries and guidelines, all of which use robust methods and methodologies in their development. So in a post-pandemic world, what does evidence synthesis look like? I would highly recommend reading a series of papers recently published this year in the Journal of Clinical Epidemiology, if this is an area that you're particularly interested in. It was a three-part series on the future of the evidence ecosystem. And they argue that this one-off approach to systematic reviews is really no longer sustainable. We need to work towards producing living evidence syntheses, so comprehensive, based on rigorous methods still, but kept up to date in a more rigorous way. And that implies, I think, a bit of a rethink of the evidence synthesis ecosystem, its infrastructure, its management. So the three distinct production systems, if you like, primary research, evidence synthesis and guideline development, really need to learn how to better work together to allow for that continuous refreshing of synthesised evidence in guidelines. The purple piece of the wedge, evidence transfer, is really fundamental to the process of evidence-based decision-making and the ability of those at the point of care to access synthesised research evidence. Evidence transfer is about advancing or enhancing both access to and uptake of evidence in local context, but it incorporates more than dissemination. Obviously, active dissemination is a part of that, and that might include things like social media or perhaps infographics. But as I said, it's more than that. It's more than those passive activities. We believe it should include things like systems integration, so perhaps the inclusion of evidence in clinical decision support systems and policies, for example, and education, whether that's CPD or online, award level education, or perhaps in services. So what does that look like post-pandemic? Well, it's interesting because there are some obvious pivots that have been made in relation to evidence transfer that I've listed here, and those are really the first three. And they've been, as I said, relatively easy to achieve. It's the next three that are perhaps a little bit more challenging, and I warned Zach that he would need to make sure he was on mute for this because it's really slightly out of my scope in terms of my expertise, but I'll attempt to explain it to you as it has been explained to me, although I suspect that there are probably people listening who are far more knowledgeable than myself. But what we're basically talking about is making evidence computable in the same way that as our approach to accessing maps, perhaps for travel, has evolved from being paper-based to being an interactive system where a voice can tell you when you've made a wrong turn. The same power as that can be applied to evidence. And this is currently a huge barrier to those that need to our ability to provide information to those who need it, when, where and how they need it. There are good reasons, I'm told, why this hasn't yet occurred, and that relates to the fact that there are no standards really internationally for how it should occur or agreement about how it should occur, and obviously every group communicates differently and in their own way, and JBI is part of that. But COVID has certainly highlighted for me the need to move forward perhaps more aggressively. This has been in the back of our minds for some time, but I think obviously this idea of a digital evidence ecosystem has been talked about increasingly in recent years and is something that we really need to have front of mind as we move forward. So evidence implementation is the last piece of the model, and perhaps a place that I'm a little bit more comfortable. Since the objective of evidence-based healthcare is optimal healthcare outcomes, it sort of seems self-evident that implementation is going to be the key to our success. And in JBI, we see implementation as being a purposeful and enabling set of activities that are designed to engage key stakeholders with research evidence to inform their decision making and to generate sustained improvement in quality of healthcare delivery. And to do that, we need to be able to establish how ready an organisation is for change, to have somebody to take the responsibility to lead it, to be a driver of change, and to be able to engage others in that process, and also perhaps obviously to be able to evaluate the process and to determine the impact of the changes that we've made. So I found the photo that's there on the right because, you know, I think this pandemic has really provided a reminder of how dynamic the world can be. It's not always calm waters like under the bridge there. Sometimes we hit some rapids that make life really difficult, and it continues to surprise and challenge the creativity, I think, of even the most experienced program implementer working across any setting. In almost all of the public health interventions that I know, the pandemic has forced a rethink of implementation plans. The pandemic's also posed critical challenges for how evaluation as a field can be adaptive and nimble when faced with flux, and the need to reimagine what's possible with system-level efforts. And I think perhaps arguably the greatest implementation success from this experience has been around personal hygiene, and in particular hand hygiene. And I read recently, I think it was 98%, there's been a 98% reduction year on year in Australia of the flu virus. That's been attributed almost wholly and solely to infection control procedures and social distancing being put in place. And I'm sure that there are similar statistics available in other countries, and I just think that that is phenomenal. So I'm really increasingly an advocate for this idea of parking the complexity that's so often associated with implementation. We know that healthcare organisations are complex, but we also need to work with more agility. And that's something that I think health professionals are really very good at. I think that academics are very good at making things very complex, but we need to move to taking a more pragmatic approach to these things, establishing a baseline or a minimum of what we can achieve. And perhaps nobody who knows me will be surprised that I've got using an empathy-based approach to implementation there as part of it, because I really believe that that's something that can help us succeed in our implementation endeavours. So in JBI, we've always understood, as I said, that healthcare is complex and inimitable in nature, and it means that there is no single linear approach that will work every time to move evidence into policy and practice. Indeed, evidence will not always be, as I've said a few times now, feasible, appropriate, meaningful, or effective in a given context. And so more than ever, the overarching principles that we apply to our model are around culture, capacity, communication and collaboration are critical. And I think COVID has once again highlighted that. In JBI, we have been looking up for about the last 5 years or so. And for those of you who are familiar with us, you will probably appreciate that we've made some fairly significant changes based upon that. Of course, just as I thought we were about to put our heads down once more, COVID hit us, forcing us to once again evaluate whether we were working in the right ways to meet the needs of our constituency. And I guess the lesson is that the world is changing so rapidly that you can't afford to have your head down for too long, something that Professor Pearson was very aware of and very good at. This year we launched a new strategic plan, a new commercial agreement, and we refreshed our brand. We had planned to launch with a great big bang, but once again COVID got in the way. But we're certainly looking to reach new horizons, which is why I love this beautiful photograph. And we'll certainly need to keep our eyes up and forward to achieve that. So I just wanted to leave you with this statement, which I have borrowed from an organisation in the USA called Facing History and Ourselves. Their focus is on education. So while their remit is a little different to ours, I really think this rings true of the events that we're living through today. It's actually something that I saw a while ago, and I have scribbled it up on my whiteboard in my office because it was really powerful. People make choices, and choices make history. People make choices, and choices make history. We have an opportunity to look up, to see things differently, to do things differently, and to make different choices that will impact on the future of evidence-based healthcare. And I really hope that it's an opportunity that we don't allow to pass us by. So that's it. Thank you very much, everybody, for your attention all over the world. And I'm just going to stop for any questions.
Fantastic. Thank you, Zoe, for that fantastic presentation. We do have some questions coming in. The first one is about post-COVID, in light of issues with evidence availability. Will evidence-based healthcare increase focus on observational studies and clinical opinion as opposed to RCTs?
Well, that's a good question. And I think it possibly will. It possibly should. But as I said, JBI has always advocated for a focus on diverse types of evidence. So certainly for us, I don't think that changes. And it's simply a matter of what data is available to answer questions appropriately. So I think that's something that we've always advocated for and will continue to post-COVID.
So do you think that some of the critics of evidence-based medicine, evidence-based healthcare, are misinterpreting evidence-based medicine and evidence-based healthcare, or do you think that critics are providing valid thoughts on it?
I don't know. I think the criticisms are less and less. Perhaps it is more of a misunderstanding. And when I read what Trish was talking about, I wasn't surprised to see it. But I think that around things like inclusion of different types of evidence, maybe that is a misinterpretation or a misunderstanding, and something that feels like old news to us, but perhaps we need to advocate for a little more actively, because we've been doing it for such a long time. I think we forget that it's perhaps not as familiar to others. So we'll put that on our to-do list, Zach.
Fantastic. Okay, we've got another question about or asking if you could highlight the importance of context in evidence-based healthcare.
Sure. Well, look, thinking, as I said at the start, about the context in relation to perhaps places like Australia that were really well positioned to fight COVID compared to places like Africa. Having access to resources, regardless of what the evidence says, is a significant challenge. So, in our clinical fellowship program, we've heard lots of stories from low-income contexts where they don't have access to things like clean water to wash their hands. So we are strongly advocating globally for hand washing to prevent infection, to help with infection control. But they're not always going to have access to resources in different contexts to be able to do that. So from a sort of COVID perspective, that's been a really powerful message, I think.
Fantastic. So another one here. How would you suggest a patient-centered, evidence-based approach could be modified for a post-pandemic community?
Oh, that's a good one. I don't know if I'm qualified to answer that, actually, not being a health professional myself. But as I said in the implementation piece, I think it's about pragmatism. And my greatest fear recently has been that we've gone down some scientific rabbit holes and focused too much perhaps on the science and not so much on this idea of context and the context and stakeholders that we're trying to serve. So I guess that would sort of be my response, that that taking a really pragmatic approach and recognising all of those different elements that we talk about in the model, that yes, it's about evidence, but it is also about context, patient preference, and where you have a patient who is either not suitable for a particular intervention or simply makes the choice to not have a particular intervention, then clinical judgment and reasoning comes to the fore, and I think that's absolutely integral to evidence-based healthcare.
Yeah. So in many ways, this pandemic has acted somewhat as a circuit breaker in the ways we view evidence, the implementation of evidence, even the production of systematic reviews and guidelines, and the way we're trying to collaborate across the globe. How do you think we can maintain these changes post-pandemic, so we don't just snap back to the old ways of doing things?
That is a scary thought, isn't it? And as I said earlier, we are creatures of habit. They say that habits are really hard to break. I can't remember, somebody was telling me recently that you have to do something a certain number of times in order to make it a habit. That person we were talking about exercise and getting into the habit of doing exercise every day. But the same is true of anything, right? You have to do it a certain number of times. So hopefully one of the silver linings, which I keep looking for in this pandemic, is that, in some ways, the fact that it's gone on for so long has meant that we have had, time to instill some of those habitual practices. But it is going to be something that I think we're going to have to work very hard at. We are seeing in Australia that restrictions are being lifted, and we're all suddenly looking very relaxed. And I know that when I was in a shopping centre over the weekend, there were lots of people around. There was far less social distancing, but then there were other things like having restrictions on the number of people in a shop. So while we were out and about in the mall, there were, people didn't seem to be particularly mindful of that. Once you were in a shop, there were restrictions on numbers. There was hand sanitizer at the door. So, perhaps those things will continue. I certainly hope that they do. I think it's something that perhaps organisations like JBI, from an evidence-based healthcare perspective, are going to have to lead on and continue that dialogue and discourse to make sure that we're encouraging people to continue with those really positive practices that we've seen occur throughout COVID.
Fantastic. We've got a lot of questions to get through, but unfortunately we're starting to run out of time. But I did want to bring this last one up because I thought you would like this one, Zoe. You mentioned empathy in implementation. So given the upheaval of COVID-19 in many healthcare systems, what role do you think empathy would play in evidence-based healthcare in this context?
I think it has. I think it does. I think it does every day. I truly believe that empathy is something that can be taught. I don't think it's something that we are all particularly well skilled in. And it's something that you hear talked about a lot. And in particular in the implementation literature, you hear reference to empathy, but quite often we don't see anything more than that. So I would really advocate for more people to be looking to empathy as a strategy for engaging meaningfully across all of those parts of evidence-based healthcare. So it's really part of stakeholder engagement right from the very start through to the end, not just in implementation, but as I said, we were questioning some of the reviews that we've published in one of our journals a couple of days ago, and a lot of that is around stakeholder engagement and establishing what the information and evidence needs are of our constituency. And I think empathy can be used equally there as it can be when you're trying to engage stakeholders in a change process to implement evidence at the point of care.
Fantastic. Thank you, Zoe. Well, unfortunately, that's all the time we have for questions. So I just wanted to say a huge thank you to Zoe for that fantastic presentation. I hope everyone enjoyed the presentation today. As I mentioned at the start, this is the first of a series of JBI Live webinars, and I'm very pleased to announce that next month we will have Associate Professor Andrea Tricco providing a webinar on scoping reviews, which seem to be very popular at the moment. And for those of you joining us from the Americas, the time zone will be a lot nicer for you at that next webinar. So please do register for that, and I'm sure it's going to be fantastic. And just summing up today, or finishing up for today, I just wanted to once again thank everyone for joining. If you would like more information on JBI education, please do visit our website, and you can find more information about our courses, some of which have gone online during this pandemic. That's one way we've had to be nimble and agile as well, as Zoe talked about. And we also do have our JBI YouTube channel where you can access some videos and former presentations and other really interesting things about JBI. Once this webinar closes, you will be prompted to fill out a very short evaluation, and since this is our first webinar, it would be really fantastic if you could take a couple of minutes just to give us some feedback so we can keep improving. But just before I finish off today, I'd like to once again thank you sincerely, Zoe, for that fantastic presentation. Really appreciate it. And also a huge thanks to the JBI education team and communication teams who also worked on today. But thank you everyone for your attendance, and hope to see you all next month for Andrew's presentation. Thank you.